So good evening, everyone. On behalf of RPO, uh, I am Dr. Padmashri Srinivasa. I am the Vice President for this organization, and I warmly welcome you all to our very interesting talk this evening um, that focuses on the neurological effects of vaccines. We have a very distinguished speaker tonight, Dr. Dr Bakshi, who's a fellow of the American Academy of Neurology. In addition to general neurology, she has a special interest in electrodiagnostics. She's involved in research projects with the Division of Research at Kaiser and UC Berkeley. She has an interest in global health and has taught neurology internationally in many different countries over the years. She has been with Kaiser Permanente since 1996 and is the Associate Chief of Neurology for Kaiser Permanente in the Diablo area. She's also Associate Professor of Neurology for California North State University and University of California in Davis. Since 2007, she has been involved with Kaiser Permanente Division of Research in the Vaccine Study Group and has authored many studies focusing on neurological adverse effects of vaccines. So much of the topic for today has been derived from her work in this space. And I'm absolutely excited to have Dr. Bakshi present on this very relevant topic for today. Dr. Bakshi, you can take it from here.
Thank you, Shri, and thank you, Raj, for inviting me to do this talk. If you'd like, I can start right now, or if you are expecting a few more attendees, we could maybe just take it a bit slow. It's really up to you.
Why don't you just go ahead,
people join as they can.
Now. Yeah.
Awesome. Yeah. Okay. So I do have a lot of content here, and I hope it can find its relevance in today's environment where we're facing an unprecedented pandemic. My talk was basically brought about because there were a lot of questions posed by my colleagues asking, well, what about a situation like this? And what about a situation like that? And for example, there have been instances where healthcare workers, now that there's a mandate to be vaccinated, are asking for medical exemptions based on fears of having some neurological event in their past history. Not that there is any relevance to the current pandemic, but those are the fears people have. So I wanted to bring to light some issues pertaining to this, and let me get started. As we all know, vaccine hesitancy plays a major major obstacle in achieving large-scale vaccinations. And one of the bigger fears has to do with people's nervous systems, what they hear either through information or misinformation, and how is it going to affect their life? How are they going to get through it? And maybe they might get disabled and so on. So my talk today will focus a little bit on the history of vaccinations, although that could be a topic in and of itself. It's a very large topic to cover, and I don't intend to do that. But just to highlight how it relates to today's pandemic and how did we even get here. I'll talk about influenza vaccination and Guillain-Barré because that topic is again going to come up sooner or later around the time when we start vaccinating people with the flu vaccine. There have been concerns about demyelinating events of the central nervous system, particularly transverse myelitis or ADEM, and how those might relate to vaccination. And then, of course, the media is abuzz with these events and adverse events, or sometimes even over concerns about possibility of COVID-19 vaccines causing things like Guillain-Barré or stroke and so forth. So that, as we know, when events occur, they are often temporally associated with vaccines, but a temporal association doesn't therefore imply a causal association. The two might be different. And it requires a lot of large-scale vaccine studies in order to really decipher whether or not there was an actual association with vaccination. So the history of vaccine research and vaccine controversy, it dates back to the 1700s or even before that. And we all know, and we credit Jenner for the smallpox vaccine. However, the idea of vaccination really started in the 1500s, we think, in countries like India, China, and the Middle East, where people used a method called variolation, which was essentially inoculation of a germ into the skin, and in this case, smallpox. Little crusts or scabs of smallpox from infected people were injected into the skin of healthy people in order to prevent the healthy people from dying of smallpox. So that's been the history. And as the history evolved, so did the controversy, so did the fears, such that the smallpox vaccination, once it started in the US, also went through its ups and downs, similar to what we're experiencing right now. Same with polio. Polio, there was a big epidemic in the US in 1945, and there was a mass immunization campaign in the United States. And unfortunately, there was some incident called the Cutter incident, where a lab that made the polio vaccine, and this lab was out of California, somehow ended up causing polio in healthy people. And it had to do with, again, the type of vaccination, the methodology of the live vaccine. These were live attenuated vaccines. And as a result of that, the polio vaccination campaign had to be paused for a while. And it was only until the 1990s and later that, again, they had to revitalize these efforts of global polio vaccination, such that now a large part of Southeast Asia is polio free. And of course, in the Americas, there hasn't been a case of polio for many, many years. Polio hasn't fully been eradicated, however. I think there's still some work to be done in some countries like Pakistan and Nigeria. And then we come to influenza vaccination. This all started around the time after the swine flu, the 1918 swine flu, as we now know very well. It killed 50 million people right after World War I. And after that, it was, largely the US effort here to develop a vaccination for influenza. And we all subject to getting our annual flu shots, which has kept millions of people relatively healthy during the winter months, especially our immune compromised and elderly population who are susceptible to dying from influenza. And as vaccines become more and more successful, as you know, they can be their worst enemy. And this has been proven to be the case with the measles vaccine. As it became successful, and who knows measles, nobody ever heard of a case. So why vaccinate? There were these fears and myths about measles vaccine causing autism, measles vaccine causing other things. And lo and behold, we had outbreaks of measles in our communities. The other fears have to do with how vaccines are developed. First of all, a vaccine is something that's given to a healthy person. They're feeling just fine. The method of introduction is usually by inoculation, which is a painful procedure. And so people tend to want to dismiss that until such time as they have a logical explanation in their minds of why to get vaccinated. Others have fears of how vaccines develop using embryonated eggs, and a lot of times chick embryos were used to develop vaccines. Lately, the fears have had to do with the newer technology. I had one of our medical assistants back in December when I was getting all excited to get my COVID-19 first shot come and ask me very quietly, Dr. Bakshi, have you heard this causes some problem in your DNA? And I said, no, it doesn't cause any problems in your DNA. You should go ahead and have it. I'm getting my vaccine. So we have a lot of work to do as physicians to educate not only ourselves, but our patients, our colleagues, our coworkers, as to what really is something we need to worry about and what is something that we need to kind of put aside as misinformation. This is a book. If anyone's interested in getting into the details of vaccination and the controversies surrounding vaccines, and there's a great chapter in this book about vaccines and autism, and we all, probably pediatricians, know this story very well. It was all really a bunch of nonsense that vaccines came to be associated with autism through some nefarious publications by Wakefield, this guy from Britain. But anyway, Dr. Chatterjee is a colleague of mine, my medical school partner and ex-roommate, and she edited this book. It has a lot of chapters from renowned authors, and it goes over all the side effects you can possibly think of and what's known to date about their vaccine side effects. Of course, this was written before the COVID pandemic came about, and it also includes a chapter that I authored on influenza vaccines in Guillain-Barré. I'll be talking a bit about that as well today. So again, this was a poll from the New York Times, July 5th, survey done. And we tend to politicize this and think that people who remain unvaccinated somehow have a political motivation, but that's really not the majority. Most people are genuinely concerned about side effects. Now, that's 53% of people polled say that they were worried about side effects, didn't want to get vaccinated. And then you can see the few that say they don't trust government, some don't believe in it. And interestingly, 7% had said that their doctor didn't say they should get vaccinated. And we're talking about the COVID-19 vaccine. We're not talking about influenza vaccine here. So in the middle of a pandemic, despite a lot of people dying, the media just full of horrific stories. Everybody knows how horrible it is. They've had their own family members or friends affected. These still are the numbers we're facing. So it is a challenge. So just to familiarize people who may not know all these agencies, we know the CDC and FDA, but this is where our public health dollars go and are put to good use. The ACIP, we've heard them a lot because they are the people who basically advise the FDA on whether a vaccine should be allowed and in what age group. The ACIP is the Advisory Committee on Immunization Practices. If people are not familiar with VAERS, then I would encourage you to look at the VAERS website. VAERS is the Vaccine Adverse Events Reporting System, and this was established in 1990. It's basically a passive reporting system such that if any person, any physician, any clinician, in fact, any patient has a event that they need to report that they think even might be related. They don't have to prove it was related to the vaccine, but there's enough suspicion that they would like to report it, that it can be submitted to this website. And the link is right here, www.vaershhs.gov. We are required as physicians to report serious adverse events, and a serious adverse event would be something like a vaccine administration error, whether or not that was associated with the adverse event. And we're also supposed to report any serious adverse event that leads to hospitalization after vaccine, which almost all the time happens, such as anaphylaxis, but also other significant side effects that lead to a patient getting hospitalized. CISA is the Clinical Immunization Safety Assessment Project, and I've been involved in some of the CISA calls. And what they do, they're a national network of vaccine safety experts. They basically, the kind of cases that lately have been coming up to CISA have been things like the patient got brachial plexopathy in the same arm as they got the vaccine. Do you think it's safe enough to go ahead and have the second dose? And those sorts of questions are posed to a large panel, and these are all experts in the field of neurology or immunology. Sometimes they have other vaccine experts throughout the country sit in on the calls and determine, first of all, whether the event was related to the vaccine, if we have enough suspicion to say that is based on prior data and prior knowledge, and whether or not that person then would be safe to get a second dose, for example. But that's not all CISA does. These are the current CISA project sites. And as you can see on the West Coast, Kaiser Permanente, Northern California is the only participating site. Most of them are on the East Coast. So coming back to how did influenza vaccine and Guillain-Barré get connected together? As you know, Guillain-Barré is an immune-mediated polyneuropathy, and on average, about 3,000 to 6,000 people in the US develop GBS every year. So that's about 10 or 20 people per million every year, mostly in the winter season, in the flu season, around the spring as well. What happened in 1976 was that there was a pandemic of influenza in the US, and it was a newly identified H1N1 strain, which had antigenic similarity to the 1918 swine flu. President Gerald Ford was in charge at the time, and there was a lot of concern that, like the 1918 swine flu, this would basically devastate the country. So they decided to come up with the National Immunization Program for Influenza and wanted to mass vaccinate the entire US population. So between the months of October and December of 1976, 35 million doses were distributed to all age groups. And in the ensuing months, there were a few cases reported from different states that seemed to raise alarms that there might be a higher incidence of Guillain-Barré among the vaccinated group compared to those who hadn't received the vaccine. Even though this pandemic didn't really materialize, it was feared to be a big pandemic, but it didn't materialize to be a pandemic of the magnitude that they feared. Regardless, because of these cases that were coming out from different states, what they did is to really put a pause on this immunization program and stop it. After that, they started to do mass surveillance of GBS to see, well, all 50 states had to report every case of GBS that had GBS meaning Guillain-Barré syndrome that happened between October 76 and January of the following year. And their initial conclusion was that there was a higher risk of Guillain-Barré in the 6 weeks post-vaccine. And the estimated attributable risk was estimated to be less than one case per 1,000 vaccinations. It's still a very small number, but yet enough that there was this link made forever, and it persists to this day, that influenza vaccines can cause Guillain-Barré syndrome. In the next few slides, I'll talk about what happened in the subsequent years. But basically, 1978 to 2007, there were a lot of other studies from Europe as well as the US that showed there was either no risk or very low increased risk of developing Guillain-Barré. And that number, it's a good number to keep in your mind if a patient were to ask you, is less than 1 in a million. So other than the 1976 influenza epidemic or outbreak, there have been really no major risks associated with the influenza vaccine. And if there is a risk, that risk is less than 1 in a million um, for people developing Guillain-Barré from the influenza vaccine. So this was one of the major studies that my colleague Roger Baxter and I participated in, and we published in 2013. What we did is to look at, since Kaiser has this huge database of patients, we went back looking at medical records, 1995 through 2006, and we pulled medical records of every case of Guillain-Barré syndrome. We classified them based on certain outlined criteria. There's a Brighton collaboration that basically lists whether or not a case can meet that definition. Brighton collaboration has definitions for things like, vaccine-related anaphylaxis and vaccine-related other things. But Guillain-Barré syndrome, the basic criteria needed, and those basically have to be met before we can call it a case of Guillain-Barré syndrome. A lot of times people get admitted to the hospital and they think it's possible GBS because the workup hasn't been done, the lumbar puncture hasn't been done, or electrodiagnostics are still pending. And what ends up happening is the ICD code picks it up as GBS. And we had to go through this entire database to see how many of those actually met the criteria for GBS. All the patients that did meet the criteria for GBS in this large retrospective study, we did not find any evidence of an increased risk of Guillain-Barré syndrome following vaccinations of any kind. And this checked for, basically influenza vaccine, Tdap, pneumococcal vaccine, and others. In 2009, the H1N1 influenza pandemic came about, and there was again concerns that this H1N1 strain had some similarity to the 1976 influenza virus. So while there was a lot of emphasis on vaccination, there was also a lot of emphasis on making sure that there was no increased risk of Guillain-Barré syndrome with this strain of influenza vaccine. And widespread surveillance was done. In fact, I remember the state of California asking for records of anybody admitted with GBS, and then those records had to be then reviewed to see if there was a temporal association within 6 weeks of having received a vaccination. They collected a lot of information, and from this, the CDC and the vaccine study groups came up with the fact that basically if there was an excess risk, that excess risk was no more than 0.8 cases of Guillain-Barré syndrome per 1 million vaccinations, which is really similar to the number I told you earlier, which was about 1. This is even less than that. In Europe, they did a similar surveillance, and their results were that there was absolutely no increased risk of Guillain-Barré syndrome after they adjusted for seasonal influenza. One of the things that comes about is when patients have had a history of Guillain-Barré syndrome, and maybe they had the Guillain-Barré syndrome happen somewhere within the 6 to 8 weeks after any vaccine. The question comes about, years later is whether they can go about getting their flu vaccine, whether they can get their shingles vaccine, or could they get any vaccine going forward, particularly the influenza vaccine. And as you know, when you go to get vaccinations, there's a form that you have to fill out that says, are you allergic to eggs and have you had GBS and so forth. So what we wanted to do was to see whether there is a risk of Guillain-Barré happening a second time. First of all, recurrence of Guillain-Barré is extremely rare. We identified 550 cases over 33 million person years. Well, we found only 6 individuals, which is about 1%. 1% of that's 550 cases had a recurrence of Guillain-Barré syndrome. And of these 6 people that we identified, none of them had any relation or any vaccine exposure at all in the 2 months prior to their second attack, second onset of GBS. So now the ACIP has softened its stance. It used to be that until about 2 years ago, they recommended avoiding influenza vaccine in people with prior history of GBS within 6 weeks of vaccination who were not at risk for severe influenza complications. So that if you're a healthy 40-year-old and you'd had some GBS happen with a prior vaccine of any type, they said not to get vaccinated with the flu vaccine. But as people get older, their risk changes. And now the stance is that it's a precaution, not a contraindication. So at least we've made some progress in that. The association of influenza vaccination and Guillain-Barré syndrome is not such that we need to really worry about that right now. When it comes to transverse myelitis and ADEM, ADEM is acute demyelinating encephalomyelitis. There were anecdotal reports that these could be related to vaccines, and there's always going to be 1 or 2 cases of something associated with something else that makes it into publication. But looking at this in a large scale can give us a better perspective as to whether there actually is a relationship. And again, this was a very big study. We studied a lot of patients. We studied 64 million vaccine doses. We basically didn't find any association of transverse myelitis and prior immunization. And as far as acute demyelinating encephalomyelitis, again, there was almost no relationship except for maybe a possibility of some associated increased risk with the tetanus, diphtheria, Tdap vaccine. And even if that there was a risk, the excess risk was not likely to be more than 1 case per million vaccine doses. So just a quick word about Shingrix and Zostavax. I won't spend too much time on this because I want to move on to the COVID-19 vaccines. Shingrix, as you know, is basically a newer vaccine. Zostavax has been phased out. And just a word to say that although there haven't been any large-scale studies, there had been some concerns that the CDC had collected together with VAERS, with the Vaccine Adverse Event Reporting Group, that maybe there's a slightly higher risk of GBS with Shingrix than with the usual influenza vaccine. So here the number is about maybe 3 to 4 in a million. And that's something to consider because if you have patients who can otherwise get shingles and have really bad complications, particularly immune suppressed individuals, then the risk of vaccination in those people is relatively low. In fact, very, very low compared to some really devastating effects of developing widespread zoster, disseminated zoster in an immune suppressed state. But in March of this year, the FDA placed a warning that GBS be included in the prescribing information for Shingrix. So now getting to the meat of the talk, these are the COVID-19 vaccines that we are using and globally are being used. There are several others I might not have mentioned names of, but the big players here are the Moderna and Pfizer mRNA vaccines and the Janssen and AstraZeneca, which are the basically live attenuated viral vector vaccines. Other manufacturers globally, Sinovac, Covaxin, Sputnik, they really haven't been used in as much of a large scale as the first 4. So I'll focus my talk on the top 4 vaccines, particularly the mRNA vaccine and the Janssen vaccine, which we've been using in our country. These were the concerns that have come up into play into the press and into the media so far. cerebral venous sinus thrombus, GBS, Bell's palsy, and then a smattering of other anecdotal reports that really haven't made it into a big way of being a concern. In about July of this year, after the Janssen COVID vaccine had been out and being used for a few months, by then VAERS had collected that there were about 100 cases of GBS that had occurred temporarily within a few weeks of the patient having received the J&J vaccine. And of these cases, the majority of them got hospitalized. They were mostly older males, and the median age was about 57. This led to a concern for a while, and I'll tell you about that concern in a minute. But when you compared the crude VAERS GBS per million doses, it really stood out. Whereas Janssen, if you look at the column on the right, per million doses, you had 8.1 cases per million. These are crude estimates. With Moderna, it was 1.2 and Pfizer 1.05. And so as I mentioned, the background rate is about 1 point something for any vaccine. The Janssen vaccine clearly seemed to pose a big problem. For a while, this was paused, the vaccination campaign. But after a while, they did some analyses to determine what the benefit would be to the population of having this vaccine still be available. Keep in mind at that time, vaccines were not in abundant supply. So they placed a warning in the fact sheet about GBS and proceeded with the immunization and didn't hold it. We are collecting our own data, and what we found seems to also suggest that there is a slightly higher incidence of GBS occurring after the Janssen vaccine, and the mRNA vaccines so far haven't shown to be much of a problem. So in our analysis, we found that within the 21 days, we had basically 38 cases of GBS confirmed. 10 were after the Johnson, 18 after the Pfizer, and 10 after Moderna. But keep in mind the number of vaccinations were much heavily skewed towards the mRNA vaccines, and there were relatively few. There were 12 million mRNA vaccines administered, whereas 406 of the Johnson. From Europe also, there have been some reports of Guillain-Barré syndrome occurring after the AstraZeneca COVID vaccine. And their numbers, their estimate is that about 4.3 GBS cases per million doses. Again, this is slightly higher than our influenza number, which may be 1 per million. Here you've got 4.3 per million. And in the case of the mRNA vaccines, we've done many studies, and I'll be telling you about another one recently that we did at Kaiser and showed really there's no increased risk. Cerebral venous sinus thrombus. This is a condition that affects basically the cerebral veins, and just like DVT, a clot can form. Unfortunately, when it happens in the cerebral veins, it causes strokes or increased CSF pressure and can lead to blindness and disability if it's not treated immediately. In the general population, the incidence is about 0.2 to 1 per 100,000. It happens more in women, possibly because, again, females are more prone to oral contraceptive use, pregnancy, and other risk factors that promote clotting. Most patients with CVST, at least 80%, have at least one identifiable risk factor, and many have more than one identifiable risk factor. Other risk factors include head trauma, infection, especially head and neck infections, or coagulopathies. And as we've seen, anybody working in a hospital setting knows very well that people infected with COVID-19 have a much higher risk of developing blood clots. And the incidence of venous thromboembolism in COVID-19 patients ranges anywhere from 7 to 28%. So our VAERS data basically collected information through April. And what they found was that, again, unfortunate, though I don't mean to be beating up on the J&J, it's a great company doing really great work, but the vaccine here did raise some concerns about cases of CVST associated with thrombocytopenia. And when they compared that to the Pfizer-BioNTech vaccine, there were no reports after almost 100 million doses. With Moderna, there were 3 reports, but in looking back, these 3 cases didn't quite meet the same definition of the vaccine-related thrombocytopenia. So that these were possibly just causal, not causal associations, but temporal associations with CVST that happened with Moderna. So as a result of this, again, the blood clot events, the vaccination campaign again came to a pause for a while. And for a while, they were recommending vaccination only for adults over 50 with the Janssen vaccine. And there was a warning placed that women less than 50-year-old, if they had a choice, should not get the Janssen vaccine. They should preferably get a different vaccine. Same with the AstraZeneca vaccine. In Europe, similarly in April, there were several case reports of CVST happening in patients. And their estimates to date have come up with the number that the risk of CVST after an AstraZeneca COVID-19 vaccine is about 1 in 40,000. This is a study, and just to highlight the fact that basically when they looked at what the risk benefit ratio would be for people, whether or not to continue using the J&J vaccine, the column on the right proved that if you're over 50 and you're a male, your risk of developing a blood clot is almost 0 versus the number of hospitalizations prevented, about 2,800, versus looking at females on the left, hospitalizations prevented, relatively low, risk of blood clot 7. So if you look at those numbers, it would seem like it makes sense if you have a choice to tell women who are younger to get a different vaccine. The advantage, though, to to the Janssen vaccine that was that it is, and still is that it's a single dose vaccine. So this term vaccine-induced immune thrombotic thrombocytopenia is a relatively new one, and it came about because of these reports from Europe of blood clots, and especially CVST happening in people who had received the AstraZeneca or the Janssen vaccine. We know now that it can happen anytime between 5 and 30 days post-vaccination, most likely happening within the first 2 weeks after a vaccine. Most of these people who got this condition did not have any other predisposing factors. And we know that this is now relating to an antibody. The vaccine basically induces an antibody to platelets called PF4, platelet factor 4. And what happens is that triggers the coagulation cascade and results in clots forming. The highest number of cluster of cases was reported from Norway, and most of those happened to be in women. And it's possible because female healthcare workers were the group that were being initially vaccinated the most, and most were young women. So it's possibly that those numbers were skewed towards young women because of that reason. The difference here between vaccine-induced thrombotic thrombocytopenia and your usual DVT is that these patients generally have much more severe outcomes. The clots happen in unusual locations like the splanchnic vein or the ophthalmic vein, and of course the cerebral veins, and lead to death basically. And so even though these were small numbers, the outcomes were not good. If you have a suspected patient with VIIT, vaccine-induced thrombocytopenia, the recommendation is to send out the lab for platelet factor 4 antibody. This is an ELISA test, and it may take a day or two to come back. But in the meantime, start immune globulin, 1 gram per kilo per day for 2 days. Since this condition is similar to, but not the same as heparin-induced thrombocytopenia, the recommendation is not to use heparin, but to use a direct oral anticoagulant. There's no consensus yet on steroid use, but platelet transfusion should be avoided for obvious reasons because there are antibodies floating around to platelets. Usually these are complicated cases and require the help of a hematologist and also sometimes vascular neurologist. Needless to say, if there is a case temporally associated with a vaccine, this should be reported to VAERS. And hopefully we won't see too many of these now because we're mindful about the age group in which the adenovirus vector vaccines are being offered. So of course, needless to say, when you compare CVST in recipients of adenovirus-based COVID-19 vaccines, and then compare them to what's the chance of getting brain blood clots after COVID-19 infection, the infection, of course, overwhelmingly is much bigger of a risk than any vaccination. So CVST after the AZ and the J&J vaccines is about 0.9 per million, and CVST in patients who have COVID-19 infection is about 2.4 per million. So definite increased risk. As far as CVST and mRNA COVID vaccines, there's no increased association, no risk basically that should come to be. So I know these are a lot of numbers to digest, but this was an exciting and big study published in JAMA just this month. It just came out from our vaccine study group, but it was a large collaboration. There were 8 health plans participating. 11.8 million doses of COVID-19 mRNA vaccines were given to 6.5 million people. And what the outcome of this study was, and it's an ongoing surveillance, it's not stopped yet, but there were no increased signals, no increased risk of acute MI, no increased risk of Bell's palsy, cerebral venous sinus thrombus, Guillain-Barré, all the stuff that we're really worried about. Myocarditis, pericarditis has also been implicated to be a concern. But looking at numbers, looking at these huge aggregate numbers, that it didn't stand out. There were no safety signals that came about from this study, saying that the mRNA vaccines have been extremely successful and extremely safe. Back in when these vaccines were being developed, there were a couple of concerns that in the phase 3 trials, there were 4 cases with the Moderna vaccine and 5 cases with the Pfizer vaccine who came down with Bell's palsy. So there was a little bit of concern that maybe their Bell's palsy could be a side effect of the vaccine, such that in Israel, they did a case control study and they found no increased risk with the Pfizer BioNTech vaccine. And they studied patients basically from January through February of 2021. Slightly different with the experience with Sinovac in Hong Kong. There seemed like there was a slightly increased risk with that vaccine. And again, they compared that to the Pfizer vaccine and their background population, and the Pfizer vaccine did not stand out with any increased risk. So overall, basically, none of the evidence that we've collected so far has resulted in any definitive evidence to inform the choice of vaccine in people with a history of Bell's palsy. My own recommendation would be if a patient basically has had Bell's palsy, that there is no reason to withhold any type of vaccination for that matter. As we know, the pandemic rages on and it continues to spread globally. As of September 7, worldwide, there have been more than 4.5 million reported deaths. And that's reported. I highlight that word because really unreported deaths probably are several times that number. But in the US, we know we've had more than 667,000 deaths. This is a pandemic that's not going away. Basically, we need to expand the vaccination programs, not only within the US, but globally. We need to distribute and make vaccine equitable. This is a quote from Franklin Roosevelt. He had polio himself. So no better person to quote this: nothing to fear but fear itself. There have been a lot of vaccine doses administered in the last few months. Hopefully we'll keep increasing our vaccine efforts to globally vaccinate our world. The WHO says vaccine hesitancy is one of the biggest threats to global health. And I just thought for good fun, I'd add this photograph. This was taken in Cambodia in 2011. I had gone on a trip to teach neurology to medical students at 2 medical schools as part of a volunteer program. And unfortunately, it's a big portion of the globe that is still suffering a lot. And we as people here in the United States are so fortunate to have what we have. The story of COVID-19 vaccines is not going to be over. There'll be many iterations, many variations, and it's up to us to really carefully study and look for potential side effects, inform ourselves, and educate our patients. I just want to basically highlight this fact here that we are one of the nation's largest research facilities outside of a government or university setting. This is the Kaiser Permanente Division of Research. We're located in Oakland, California. We work closely with the CDC And there's a lot of studies that have come out that have benefited our population and also made a global impact. I also want to acknowledge my friend and my colleague, Dr. Roger Baxter. He was one of the authors on many of the studies I mentioned and brought to your attention today. He unfortunately passed away in 2016. So I'm going to end my talk. I thank you for your patience and for listening, and I'm happy to take any questions. If you have questions, please add them in the chat.
Thank you so much, Dr. Bakshi. That was an amazing presentation, very relevant for the crises that we face today. And I can't tell you, in the hospital setting, there's not a single day that goes by when I haven't had patients that I had met with COVID-19. And, you know, many of them have had this fear of getting vaccinated because of all the, you know, conditions that we just discussed. You know, this is going to be an ongoing discussion with our patients, you know, a conflict, if you will, between the physician community and the patients who refuse to get vaccinated and lead to the perpetuation of these infections in the community. Just FYI for all our members who participated in this wonderful talk, this has been recorded and will be posted on our website. You know, just to avoid crosstalk and ensure that everybody in the group gets an opportunity to, you know, post their questions to the presenter, I would request that everyone post in the chat board if they have any questions for Dr. Bakshi. I'm just gonna unmute all. So you can unmute and ask questions if you feel. So there is a question from Dr. Kale. What about the adverse effects of myocarditis in 16 to 39-year-olds and any updates on the booster dose?
So as I'm a neurologist, my focus was on neurological adverse events, but I would refer you to the article by Klein, Dr. Nicola Klein and colleagues. This was a multi-center, really, really large study. And in that study, that analysis, it didn't show any increased risk of myocarditis and pericarditis. That doesn't mean to say that there haven't been any cases. Again, this was adult age group over the age of 12. So that did include adolescents. There were 6.5 million patients who received vaccines. Most of them were the Pfizer BioNTech, but there are also a good number of Moderna. I think it was 2/3 of one and 1/3 of the other. But basically, those were mRNA vaccines. This study did not include the Janssen vaccine.
Thank you.
Dr. Bakshi, I have a question about Moderna. The immunity, I heard it's stayed up to 94. Do you recommend the booster, the third vaccine? For the
that's a great question. I'm also watching that with a lot of interest. I myself had received the Pfizer vaccine, so I'd be anxious to get the Pfizer booster as soon as it's basically allowed by our hospital center. I think with the Moderna, we don't really have that recommendation in writing as yet. They're working hard at it. And this is beyond my pay grade. The ACIP, in conjunction with the CDC, basically come up with these guidelines, and they really look hard and fast. There's a lot of experts involved. They have to look at the data. Once they make this recommendation, it's applicable not only in our country, but we're the leaders. Everybody's following our cue.
Sure.
So we have to be sure that what we do makes sense. And at the same time, there is pressure, as you know, from the WHO to not just be frivolous with vaccine use here and just say we should use extra doses just because we have them. Really, there has to be some science behind it. If there is waning immunity, by all means, I think we should.
But Pfizer, at least the immunity came down to 72 or 74, but that Moderna is 94. If you have that high immunity, if you take the booster, do you have any it's not going to go up that much? And also too, do you get any side effects? That's my
That's
concern.
exactly, we don't know that.
Yeah,
We don't
right.
know that. Time will tell.
Yes,
Right.
thank you.
Dr.
Thank you.
Bakshi, I have a question for you. So we know that India is one of the biggest vaccinators in the world right now. So Covaxin and Covishield, I don't know if you touched upon those vaccines. I know there was something about Sinovaccine in the talk, that there was an increased risk with it. What about the risks associated with Covaxin and Covishield?
To my knowledge, they haven't been studied in the magnitude that these studies I mentioned today have as far as neurological side effects. The neurological side effects of vaccination, the large scale studies need to be done. And to my knowledge, there haven't been any major signals associated with CVST and the other vaccines, but there could be. Again, my
Okay.
focus was on the vaccines we use here in our country, and it's a relevant question, and I'm sure there could be possible side effects. It's just when it comes to things like CVST and Guillain-Barré syndrome, there's been no real major safety signal yet. I still think whatever vaccine's available, people should get it. And in general, when you look at these numbers, they are so small the risks are such small numbers, minuscule numbers when it comes to the millions of people that are dying from COVID infection.
Absolutely. But no preliminary data that you have seen, right?
I have not. I didn't look into
Okay.
that specifically for the purpose of this talk today.
Awesome. All right. Any other questions?
Oh, that's an excellent talk.
Could you post your questions, please,
Oh,
on the chat board? Thank you.
You are unmuted in there. So if you talk, it will go to everybody.
Dr. Bakshi, can you mention anything about this increase in children, the COVID infection in children, pediatric age group?
So as far as vaccination, neurological side effects in the pediatric age group, that is still remains to be seen. We haven't yet had large-scale vaccination for the pediatric age group for long enough to really come up with any data about it. So if any of you are pediatricians and you have any case that you're even remotely concerned may be vaccine related, I would encourage you to report it to VAERS. What the VAERS team does is scrutinize each of these cases. They bring it forward to a committee to review. And that's how these safety signals even came to be. The reason that they picked up on these early cases of blood clots and early cases of GBS was because of VAERS reporting.
Any idea on when the pediatric vaccine is going to be released? I did see some newspaper article that it was going to be released in the next month or so.
I would expect soon. I don't have the information on that. I don't sit on those committees, but I
Sure.
do know that, again, our Kaiser Division of Research did a very, very large scale study on the pediatric age group. So that study showed very promising results in the pediatric age group with the mRNA vaccines. It was specifically the Pfizer-BioNTech vaccine.
Okay.
So that information should, if not be published soon, it should be out already. So the good news is that I think it's coming and it should be there soon. The when, I don't know. That's the people that are up in Washington, D.C. and the NIH and the CDC are all sort of, I'm sure, working extra hard to push these out to the pediatric age group as soon as possible.
Yeah, I think that's the need of the hour.
That's right.
Especially with the Delta variant affecting pediatric populations more intensely than the initial strain, right? Can't emphasize the need. I do not see any more questions being posted on the chat board. We'll give it another minute. If I don't see any questions pop up, then I think it would be safe to assume that we have had all questions answered, and I would really like to thank Dr. Bakshi for your time and for this amazing presentation. I'll be going back to the recording to hear this again and imbibe some critical points there.
Sure, and if I don't know if you're making the slides available, but they can also be made available to our attendees.
No, that would be amazing. Yes, very helpful. And the recording also will be posted on our website.
Thank you.
And
Thank you all for coming. And again, thank you, Sri, for moderating. Thank you, Raj, for inviting.
thank you, Nandini. Absolutely a pleasure to have you on our talk this evening.
Good night.
Have a
everyone.
good night, everyone. Thank you so much for attending. Let's see. Thanks, Nandini.
Good night.
Good
Thank
night.
you.